Hello friends, greetings of the day. I am Dr. S.K. Malani, professor in cardiology, and today I am going to share with you some basics of ECG. So let me share my slide screen and discuss something about the basics of the ECG, right? So here we go. Now, in the part one, I'll just introduce the basics of ECG. How do you interpret normal ECG? And there are certain non-specific changes which sometimes can cause confusion in the mind of the doctor, whether they are really indicative of a heart disease or they are non-specific in nature. In the part two of the tutorial, we'll discuss something about the abnormal ECG and certain disease-specific ECGs such as coronary artery disease, cardiomyopathies, and arrhythmias. As we know that it's the most commonly employed test in medicine, and many of us who order ECG actually cannot interpret it correctly. And we do not even are aware of this inadequacy. Sometimes we can transmit incorrect information as well, which may lead to disaster. So I have made a module, the aim of which is to provide a comprehensive guide to correctly interpret normal ECG in a stepwise and systematic manner, to make the learners aware of normal variants and avoid wrong interpretation so that unnecessary treatment is not administered, and to practice a structured ECG reporting protocol which includes the patient details and the various sequential reporting of rate, rhythm, QRS axis, various waveforms, various intervals, followed by any other significant finding. What are the practical issues when you are interpreting a ECG? First of all, remember that the clinical scenario and the presenting complaints of the patient are very, very important to correlate with the ECG finding. Certain times in acute MI, say, initial ECG may be absolutely normal. But if the clinical scenario demands, the patient should be kept under observation and serial ECG should be done to come at a conclusion. Number two, do not have fear of incorrect diagnosis. Many times we get bogged down that what if I go wrong? Do not be afraid of that. And I'm telling you, if you do systematic approach in say 100 or 200 ECGs, you will be often rewarded by correct diagnosis. Whenever in doubt, do discuss with your seniors or who are more knowledgeable. And do follow the patient and serial ECGs at every opportunity, if possible, to enhance your skills further. Let us discuss a little bit about ECG paper. All you know that ECG paper has got a small box and a large box. They mean different in time domain and distance domain. So one small box is 1 millimeter and one large box is 5 millimeter. Similarly, in time domain, you have 40 milliseconds or 0.04 seconds as the one small box and 0.20 seconds or 200 milliseconds as one large box. In the vertical axis, generally, we measure the amplitude, and that is one large box is 0.5 millivolt or 5 millimeter is 0.5 millivolt. Now, always look at the standardization deflection, which is at the start of the ECG. All leads, prior to that, you will find a standardization ECG deflection. This should be calibrated normally at 10 millimeter per millivolt. Half of this will be 5 millimeter, that is half standardization. If you have very large voltage QRS complexes, you can go for this, or double amplitude, which is 20 millimeter per millivolt. Now, if your calibration is not correct, sometimes there is a problem of over damping or under damping. If you have a correct calibration, then all the corners will be square and absolutely non-distorted. If there is an under damping, that is when the writing stylus is not pressed firmly enough against the paper, you will have a sharp spike and it will distort the ECG as a sharp complexes followed by some drag on the STT segment. Similarly, when there is an overdamping problem, you will have the complexes which will be little slower and they will be more fractionated. So remember that the standardization deflection should be absolutely sharp and clearly demarcated. Let us discuss a little bit about 12 lead ECG. You all know that there are 12 leads and they include 3 limb leads, the 3 augmented leads, AVR, AVL, AVF, and the 6 precordial leads from V1 to V6. Correct localization of the electrodes should be followed to have a correct interpretation of the complexes in various leads. I'll just finish off what these leads actually indicate in terms of surface of the heart. Now let us see lead 1, AVL, V5 and V6, which are marked in a separate color. They generally mean a lateral surface of the heart. If you have changes only in 1 and AVL, sometimes it is referred to as a high lateral changes. You may have only MI localized to high lateral wall and hence you will have changes only in 1 and AVL. Similarly, inferior leads, as you know, 2, 3 and AVF are the inferior leads. V1 and V2 are generally called septal, V3, V4 anterior. However, sometimes V1 to V4 are called anterior or anteroseptal, and if you have V1 to V6, it may be called an extensive anteroseptal. What are the additional optional leads? Sometimes you might have to order, and in that you may order V7, V8, V9 leads for a suspected posterior MI. Right-sided chest leads, which are important to diagnose a right ventricular MI, or sometimes when you have a dextrocardia. Deep inspiration is a good strategy where you can repeat, particularly lead 3 and AVF, where a small Q wave may disappear on deep inspiration. Sometimes one space higher or lower ECG may be recorded, particularly for the chest leads, so that some abnormalities might just disappear and you have a correct interpretation of a normal ECG. Alternate sites can be practiced depending if the patient has got a wound, burns or dressings. And please do remember, always tell the technician, be aware of wrong lead placement on limbs causing reverse limb leads or a different pattern on ECG because of the wrong placement. The systematic approach would be to go stepwise. Generally, what we follow is that you calculate heart rate, followed by see the rhythm, whether it is a sinus rhythm or a non-sinus rhythm. I'll come to that later on in detail. And regularity of the rhythm, whether regular or irregular. The axis of the P wave, the QRS complex and T wave can be measured. However, in clinical practice, what we follow is a QRS axis in the frontal plane, which is most important. The wave morphologies, you know, P, QRS, T and U. The intervals, that is PR interval, the ST segment and the QT or QTC. Any specific finding other than these, and then the final impression. Make a practice that you start writing in this form, at least in the initial practice, to master the ECG interpretation. Now, how do you calculate rate? There's a rule of 300, that is 300 divided by number of big squares between the two consecutive RR, or rule of 1500, that is nothing but 1500 divided by number of small squares between the two consecutive RR. Especially when there are rhythms are irregular and fast, you can have a rule of 10. As you know, that a long lead is generally recorded for 10 seconds in an ECG, and hence if you count the number of beats in 10 seconds in the long lead 2 and multiply by 6, this will give you heart rate. Just an example, if you count between the two RR complexes, roughly there are about 6 big squares, and hence 300 divided by 6, it comes to 50. This is a very fast and irregular rhythm, and hence if you notice the long lead V1 at the lower bottom strip, you count the number of beats in that lead and multiply by 6, which is in this case 33 into 6, which will give you 198 beats per minute. Normal sinus rhythm is nothing but a sinus P wave followed by a QRS complex and a T wave at regular intervals. The abnormal rhythms which we may encounter is wandering pacemaker, where the pacemaker of the heart wanders from sinus node to some atrial other sites, leading to different PVM morphology. I'll show you some examples later on. The atrial rhythms, it can be junction rhythms or it can be ventricular rhythms. Normal sinus rhythm originates in the sinus node. The rate is generally between 60 and 100 beats per minute. The P wave axis is generally about plus 45 to plus 65 degree, and that is why you see tallest or most prominent P waves in lead 2, which is aligned to plus 60 degree. They are monomorphic, that is arising from the same site. The PR interval is 120 to 200 milliseconds, and there's a regular relationship between P and QRS complex. Some sinus arrhythmia in young individuals is a normal finding which can be ignored. Coming to the QRS axis, if you have one or two methods which you have mastered, this method should be followed in all ECGs. I'll show you 2 or 3 methods how to calculate the AQRS in frontal plane. Now, if you see, this is the hexagonal system where the limb leads 1, 2, and 3 are placed at 60-degree distance from each other. The positive electrode of 1 is at 0 degree, 2 is at plus 60 degree, and 3 is at plus 120 degree. Similarly, the augmented limb leads lie on this hexagonal system plus 120 degree apart. So AVF positive pole is plus 90 degree, AVL positive pole is minus 30 degree, and AVR positive pole is minus 150 degree. Remember, depending on the QRS axis in frontal plane, you will have a different morphology of QRS, positive, negative, or equiphasic in different leads. So we have quadrant method, we have an equiphasic lead method, and we have a bipolar limb lead method. Let us go one by one. This is a schematic diagram where you see the normal axis is determined between the 2 green arrows, that is minus 30 to about plus 90 or plus 100 degree, that is the normal axis. If you see between the minus 30 and minus 90 degrees, it is left axis deviation. Similarly, from plus 90 or plus 100 up to plus 180 as a right axis deviation. The northwest quadrant or extreme right axis deviation is when the axis lies between minus 90 to plus minus 180 degrees. By near consensus, what we have, if normal QRS axis is between minus 30 to plus 90, which is again shown in the same quadrant. Now determining the axis by equiphasic method, so you say QRS is predominantly positive in a particular lead, predominantly negative in a particular lead, or equiphasic in a lead. So identify the lead with equiphasic complexes. In the quadrant approach, look at lead 1 and AVF. Now lead 1, if it is positive, and lead AVF, it is positive, it is a normal axis, roughly speaking. If lead 1 is negative and lead AVF is positive, it's a right axis deviation. If both are negative, it's in a northwest or a indeterminate axis. Just a small example, I have earmarked QRS complex in lead 1 and in lead AVF. As you notice here, the QRS complex in lead 1 and AVF are positive, and hence the axis is within the normal range. In left axis deviation, note the negative QRS complex in lead AVF, and then in lead 2, if you go in lead 2 also it is negative, and hence it is definitely a left axis deviation. Next example I'll show you when it is actually a non-pathological or a physiological left axis deviation that is lying below minus 30 towards 0 degree. So in this case, if you notice that lead 1 is positive and lead AVF is negative, so we'll say okay, left axis deviation. But if you see lead 2, it's predominantly positive, and hence it is more towards plus 60 degree than towards the AVF negativity, and hence it is around minus 30 degree, thereby causing a normal axis or a non-pathological left axis deviation. Similarly, right axis deviation, what you will find a predominantly negative complex in lead 1 and positive in AVF. However, this may not be the case always. You may have a RS complex in lead 1 but predominantly negative. Look at this ECG. What you have is a predominantly negative, although there is a small r starting at the complex in lead 1, but AVF is positive and hence it is indicative of a right axis deviation. So you must see axis in many ECGs and you will come to know that whether it is a normal right axis or left axis. If you want to really quantify further in terms of say plus 30 degree blocks or 15 degree blocks, you can go further lead by lead. Now here in the equiphasic method, what you have, see the lead which is equiphasic in AVF, small r and followed by S, almost equiphasic. Go to the 90 degree of this lead. AVF 90 degree lies at 0 degree, that is lead 1. Lead 1 is positive and hence it is QRS axis of 0 degree, a normal range. Similarly, in this ECG, although fast with suggestion of some broad QRS tachycardia going on, if you see lead 2 is rather equiphasic, very small complexes but equiphasic complexes. Go to the 90 degree lead of lead 2, which is AVL. Now see in the AVL, it is predominantly negative QRS and hence the axis is somewhere around plus 150 degree, and that is how the axis is determined. The another method which sometimes we employ again to come to a 30 degree or a 15 degree quadrants are see all lead 1, 2, 3. As we have discussed 1 and AVF, you can go step by step. 1 and 3 upright normal axis, 1 upright, 2 biphasic and lead 3 negative, a physiological left axis deviation. 2 and 3 both negative and lead 1 upright, pathological left axis deviation. Right axis, you have to have lead 1 as negative and lead 2 again biphasic or lead 3 upright. And if you have extreme right axis deviation, all QRS complexes in 1, 2 and 3 will be negative, and probably positive QRS complex in AVR, which generally has got a negative QRS complex. Now let's go one by one to the different waves. This is just, I wanted to tell you that P wave axis also can be calculated if required, but generally we don't do it. Generally it is predominantly positive in 1, 2, AVL and AVF because of the normal sinoatrial nodal origin. If it is negative in inferior leads, likely origin is from the LA posterior sides or coronary sinus, and if it is negative in lead 1, again it's arising from the LA. Now T wave axis is another one which you can calculate. Sometimes you will find that there are non-specific T wave inversions which are discordant from the QRS positivity or negativity. So what do you see? Normal T wave axis is between 0 and 90 degree. So roughly aligned to the QRS axis. So if it is aligned to the QRS axis, the leads which show positive QRS should have a positive T, and leads which show negative QRS should have a negative T. Any axis change in the T wave frontal plane axis will cause some discordance between the QRS and T wave. There is another concept of QRST angle, in fact, which is normal less than 90 degree, and if you have a higher QRST angle, that is wide variation between the QRS and T wave axes, then it may be a marker of increased risk of sudden cardiac death as well. So remember and always look for a polarity of T wave in lead AVR. T wave has got no business to be positive in AVR. All complexes in AVR are negative. So if you find that T wave is positive, go and analyze T wave axis nicely. It could be because of left ventricular hypertrophy or ischemia or some other causes, but then the ECG analysis for T wave axis becomes important. What are the normal ECG waveforms? We all know it, starting with the P wave, that is atrial depolarization, the QRS complex, that is the ventricular depolarization, and the STT segment, which is ventricular repolarization, and various intervals, that is particularly PR interval and QT interval, and the ST segment analysis in the ECG. So let us go one by one. What is a normal P wave? P wave is about 80 to 100 milliseconds in duration. The maximum amplitude of a normal P wave is about 2.5 millimeter. The axis, as I told you earlier, is about plus 45 to plus 65, thereby dominantly positive P waves in lead 1, 2, AVF and V5, V6. Normally in lead 1, P is biphasic. Why? Because V1 is lying at the right side of the chest and initial depolarization of the atria is from left to right, causing a small positive deflection followed by a small negative deflection. Terminal deflection of the P wave, however, should not exceed 1 millimeter in depth or 0.03, 0.04 duration, second in duration. This is just a normal depiction, what you have in V1 and lead 2. As I said, the atrial abnormalities can cause P wave, like in right atrial abnormality, you may have P pulmonale, that is in the lead 2, you will have a tall peak P waves, and in V1, you will have again tall waves, but a smaller negative deflection because it cancels the left atrial depolarization. In the left atrial abnormality or left atrial hypertrophy, what you will have is a bifid or M-shaped complex in lead 2. The initial deflection is because of the RA depolarization, and the terminal deflection is by the LA depolarization. You can have a biatrial abnormality as well, depending on the clinical scenario. The QRS complex is a ventricular depolarization event. Normally, it is less than 120 milliseconds. More than 120 milliseconds is caused a wide QRS complex. So, normal complex is a narrow complex because it is conducting through a normal AV node and his bundle and its branches. The Q wave is the first negative deflection in the QRS complex. It's normally present in lead 1, AVL, V5, V6. It's significant or pathologic when it is one box wide, that is more than 0.04 seconds, or the height of the Q wave is more than 1/4 of the height of the R wave. R wave, as we know, is the first positive deflection, and S wave is the next negative deflection. This is the normal QRS in a normal ECG, where you find that the leads 1, 2 and V5, V6 are predominantly positive. The AVR has got a completely negative deflection. Lead 3 and AVL, the QRS complex may differ depending on the position of the heart, which I'll be coming into my subsequent slides. Now, you must realize that heart is located in the chest in a particular position. So if you see the center figure, that is intermediate position is the normal of the heart when you are looking from the top. So when you look from the top, you can have an intermediate position, or you can have a vertical position, or you can have a horizontal position. These will cause some changes in the augmented limb leads, that is AVL, AVF and AVR. The other axis of the heart is a rotation around the longitudinal axis, which is looked from the bottom. Now, if you look from the diaphragmatic surface towards the heart top, then you can say that around this axis, the heart can rotate either clockwise or counterclockwise. This will also cause changes in the QRS complexes in chest leads. Let us come to the examples of this. So now, if you have a normal heart, which is depicted in the middle of the figure, where the lead 1, lead 2, both are positive, and lead 3 has got a big R with a small s. This is a normal QRS complex in lead 1 to 3 in a normal position of the heart. Now look at the vertical position of the heart. When you have vertical position, it's more towards the inferior leads, and hence the lead 3 records a dominant R. And however, the lead 1, which is more towards the 0 degree, will record a RS complex. So you may have a normal RS complex just because the position of the heart is vertical in the chest. Similarly, come to the last figure, which is the horizontal position of the heart. What is happening? The axis of the QRS in this is more aligned to 0 degree. 0 degree, that means towards the lead 1. And hence in this, what you will find is that predominant R is in lead 1. However, lead 3, because it is at the plus 120 degree, it will record a Q wave. So don't be surprised if you have a Q wave in lead 3, isolated Q wave in lead 3. This may be just because of the position of the heart in the chest. Now let us look at the this is same picture depicted of the horizontal heart and vertical heart to tell you and what changes it have on the configuration of the complex in limb leads. Coming to the effect of rotation of the heart around the longitudinal axis on QRS morphology in chest leads. Sometimes you will find that chest leads, although they should rise and the transition should occur somewhere around V3, V4. See panel A and B, when you have a normal transition, that is either in V3 or V4, it's a normal position of the heart, right? Where the right ventricle is anterior and left is posterior and towards the left. See the picture C and D images. Now in this, what is happening? It's a counterclockwise rotation, meaning thereby that the RV is coming like this and LV is becoming more anterior, and hence there's an early transition in V1 or V2. Now see the last two panels E and F. What is happening there? The transition has gone into V5 and V6. Many times you will find that you have a small RS complex in V1, V2 and V3, which is actually normal, but when you go to V4, V5, V6 and still you find that the RS complexes are persisting, that is nothing but because of the late transition and a clockwise rotated heart, right? Okay, so much about the position of the heart and changes in QRS morphology in various leads, be it chest leads or limb leads. Now coming to the J point. J point is nothing but point where the QRS ends. You can have J point elevation sometimes in early depolarization syndrome. Hence, you must look carefully at J point and then follow the ST segments, maybe 30 or 40 milliseconds down the line. What is the abnormality of the ST segment? Now, T wave is repolarization of the ventricles. Normally, the T wave is asymmetrical. Asymmetrical means the first half having a slight gradual slope and followed by a trickle descent of the second limb of the T or descending limb of the T. It should normally be less than 2/3 of the amplitude of the R. If it is very tall, then we call them a tall T wave. The abnormal T waves on the other side are symmetrical. They may be tall and peaked, biphagic or inverted. Any morphology they can have. This is a pictorial diagram showing you asymmetrical normal T wave in the first panel. Can have a different morphology. It can be rounded top or a slightly sharpish top. However, when you have an abnormal, they will be very sharp, peaked and very tall in the lower panel. U wave is not always present. It may be present sometimes in certain ECGs and can be a normal finding. They are small, round, symmetrical and positive with amplitude less than 2 mm and generally seen in the anterior chest leads. The direction of the U wave is generally same as the T wave and they are more prominent at slow heart rates. The PR interval, as you know, it varies from 120 to 200 milliseconds. It is generally decreased in an axillary pathway or in an LGL syndrome, and it is increased when we call it a first degree AV block. Coming to the ST segment, it's generally flat, that is isoelectric. It has to be compared with the PR segment. You'll find that the ST segment is more or less in the same line as the PR segment and it is isoelectric. Elevation or depression of ST segment by 1 mm or more is always to be looked seriously. And this is the single most important element to identify and analyze when you are diagnosing coronary artery disease changes. The shape of the ST elevation may differ in different people and different acute coronary syndromes. So you must memorize many ECGs of this. It can be a coving upwards with a tall T in a hyperacute phase. It follows by development of the Q wave, loss of R wave, development of QS complexes, and then finally, very late, it may normalize, or a telltale sign of acute MI may be left on the ECG even after years. The QT interval, as we know, long QT is a cause for serious arrhythmia and sudden cardiac death. So whenever you have a doubt of patient presenting with some palpitations, syncope, you must look at QT interval carefully and measure the QTC by whatever formula you are comfortable with. It varies with heart rate, but should be less than 440 milliseconds in males and maybe 450, 460 milliseconds in females. The formulas like Bezet's, Frederick's, Framingham, and Hodges are there. However, you can simply online calculate by feeding the heart rate and the distance in the millimeter between the start of the Q wave and the end of the T wave, that is the QT interval. Now let's see the normal ECG. There are certain rules which have been practiced by many people. Professor Chamberlain has devised 10 rules of normal ECG. What do they say? They say, number one, that the PR interval should be 120 to 200 milliseconds or 3 to 5 little squares. That is rule one. Simple. The rule two is that the width of the QRS complex should be less than 110 milliseconds. Agreed? That is a narrow QRS complex. More than anything, 110 or 120, we call it a wide QRS. The third rule is simple. QRS complex should be dominantly upright in leads 1 and 2, as we know, because the QRS axis is aligned somewhere between 0 to 90 degree, and hence 1 and 2, which are falling between these quadrant, will have a predominantly positive complexes. Right? Coming to rule 4, QRS and T wave tends to have the same general direction in limb leads. As I told you, the T wave axis and the QRS axis, they are more or less aligned, and hence they are concordant. Rule 5 is that in lead AVR, all waves are negative. And hence, if you find some positivity in lead AVR of either QRS complex or T wave, please carefully analyze the abnormality considering the whole ECG. Rule 6 is that there should be progressive R wave increase from V1 to V4 at least, and the S wave also should grow from V1 to V3. That is a normal phenomenon in chest leads when you have QRS, unless the heart's position or the rotation counterclockwise or clockwise can result in different QRS complexes, which should be thoroughly explained. Rule number 7 is that ST segment should start isoelectric, except in lead V1 and V2, where it may be elevated slightly. What is the rule 8? The P wave should be upright in 1, 2, and V5, V6 at least, because we know that the axis of the P wave is somewhere between plus 45 to plus 65, and it originates from the SA node, and hence it will dominantly be positive in these leads. Rule 9 is that there should not be any Q wave or only a small Q less than 0.04 second in width in 1, 2, and V2 to V6. Otherwise, it will become a pathological Q wave. The last rule is that the T wave must be upright in 1, 2, V2 to V6 and negative in AVR, right? So let us see what are the normal variants in ECG, which may cause sometimes confusion in the mind of interpreter that whether it is a really abnormal ECG or they are normal patterns to be ignored. Sinus arrhythmia. Sinus arrhythmia is nothing but a varying heart rate in respiratory cycle, and it is very common in young person or hypervagotonic athletes. If you see in this ECG, you will find that first 2 beats are well apart. However, the rate accelerates in the next 4 beats to fall again in the 7th QRS complex, right? Persistent juvenile pattern. Sometimes you will find that V1 and V2 has got a slightly bigger R, or there are T inversions in V1, V2 and up to V3 and minimal ST elevation. This is nothing but persistent juvenile pattern and can be ignored if the clinical scenario has no significant indication of a acute coronary syndrome. Early repolarization, as we know, I told you J point, which is actually the junction of the or the end of the QRS complex. Look carefully. You will have J point elevation, which is concave upwards in multiple leads, particularly in the middle chest leads. There is a slurring or notching of terminal QRS, and it is generally occurring in young adults with hypervagotonia. Thank you, ladies and gentlemen, and I hope you enjoyed this tutorial. I'll be coming again to you to talk to you about abnormal ECGs in my second lecture.